here before, I cannot speak Spanish. I have to speak English. I would prefer Italian, but I don't know how many of you would like or can appreciate. And I would like to thank the organizer for inviting me. I have treated patients for more than 30 years. And at the Hemofilia Center in Milano, under the direction of Professor Mannucci, my chief and my master. On the other hand, I have to confess I am Italian. So be nice with me. I'm not perfect. Nevertheless, what I'm going to present is just my personal opinion based on my personal experience and knowledge. So nothing to do with Baxalta, even though I'm proud to be with Baxalta, but that's a different story. So I'm going to speak about the treatment approach, the products that are available, and the importance of ultra-large multimers and the availability of a recombinant von Willebrand factor. Why to start with the treatment approach? We have heard a lot how von Willebrand factor is working, and since the very beginning, this disease, since when it has been described at the beginning of the last century, there was a tentative to treat it with some plasma fractions, with some cryoprecipitate, because in the cryoprecipitate there is a certain amount of von Willebrand factor. And then the first pasteurized factor was available in Germany, really at the beginning of the 80s. And then it has been a continuous evolution, I would say very fast. And it has been considered the possibility it has been discovered the gene, it has been identified Adams 13, that is as we have heard, the factor that is regulating the amount of activation, should we say, of von Willebrand factor. And then in the 90s, the first recombinant factors have been tested in dogs. And today, a recombinant von Willebrand factor has been approved by FDA in the United States. And it is expected its approval next year in Europe. So the aims of treatment of von Willebrand factor is, in effect, to correct the dual effect, defect of von Willebrand factor, which occurs in patients with von Willebrand disease. And it is the adhesion defect, and that are represented by the three activities that are, so the three tests that are the dissociating factor, the collagen binding, and the bleeding time, and the low plasma factor VIII levels. So we have to compensate these two defects that are characterizing von Willebrand disease. So, and then we have to consider three main driving factors when we decide the treatment. First, we have to take into consideration the type and the severity of von Willebrand disease. So we should also know the baseline of von Willebrand factor and the factor VIII levels. And then we have to consider what is the clinical situation, whether there is an acute bleeding and how acute is. I would say where the bleeding is occurring, if it is a nosebleed, if it is a gastrointestinal bleed, if it is a joint bleeding. Surgery, if the patient is undergoing surgery, or if we want to prevent bleeding, particularly if we want to prevent menorrhagia, or we want in general to prevent gastrointestinal bleeding or joint bleeding. So it is different settings, and this is, of course, is influencing the dose and the regimen that we are going to use. And then we have to consider what kind of concentrate is available and what is the ratio of the content in von Willebrand factor and in factor VIII, because it can influence the dose and the intervals between the doses. And we have different options, so you can see listed here. The first one is desmopressin, so DDAVP, that can favor the delivery of endogenous von Willebrand factor in the bloodstream. Is von Willebrand factor concentrates containing or not factor VIII. And we have to consider additional supports, particularly tranexamic acids. So the treatment with the DDAVP, I mean, DDAVP has been in a way discovered that could favor the release of von Willebrand factor from the viable palate bodies in 1977. And I must say that this discovery was due to an observation of my chief and master, Professor Mannucci. So, and I would say that next year it will be the 40th anniversary of this discovery, which was extremely important because, as you can see, in some patients affected by some types of von Willebrand disease, desmopressin can be per se sufficient to treat the bleeds. And the bleeds can be treated with the 0.3 micrograms per kilo IV or sub-Q. And there are also preparations for nasal administrations. And it can increase the level of von Willebrand factor 3 to 5 folds in a relatively short period of time. Here you can see the advantages and the disadvantages of the treatment. Sorry. Here is the first one about efficacy, and you can see that it can be used in patients with type 1, type 2A, and type 2M. Is effective for treatment of minor, mild bleeds, shall we say. Probably for severe bleeds cannot be always sufficient. And it is very easily administered, as I said, because it can be given sub-Q or intranasal, and of course it can be given intravenously. It's relatively inexpensive, and it can be given once a day. The problem is that there is an extreme heterogeneity in response, so DDAVP test has to be done always. The response is particularly variable in children, and the repeated use in small children can be not recommended because it can cause hyponatremia. The effect is relatively short. And we can have a sort of what it is called tachyphylaxis. So after a number of infusions, the response can decrease. It is extremely safe. I mean, now we have almost 40 years of safety data. It is also used in pregnant women. The problem is that can cause some thrombocytopenia, which is transient in type 2B, and is associated with some adverse events like flushing, hypotension. And this hypotension can be associated with some causes of myocardial infarction. So, and then of course it can be used with some precaution in elderly patients or in patients with the previous episodes of myocardial infarction. And what it is potential advantage and disadvantage is that it can increase factor VIII levels, not only von Willebrand factor. And here it is presented as an advantage, a disadvantage, because of course it can be an advantage if we need factor VIII. But on the other hand, a sustained high level of factor VIII can be difficult to manage and can be a risk of thrombosis. So we will come back to that. Antifibrinolytic agents, I don't want to spend a lot of time with that, but they are particularly important in these patients, and for some mucosal bleeds, particularly of the mouth, but also some gastrointestinal bleeds can be of extreme help. Topical agents, of course, we can have, during particularly surgery, we can use some topical fibrin sealant or collagen sponges that can help to control bleeding. But of course, it cannot be used for internal bleeding, but just during surgery. And then we have a von Willebrand factor replacement, which is in effect the most important one, and must correct, as I said, the defect in platelet adhesion, plaque formation, and fibrin clot production. It concentrates, should provide a high level of safety in terms of transmission of blood-borne pathogens, infections, any kind of them. And of course, we must be careful with the intervals between infusions. Because, of course, when we administer von Willebrand factor, we are going to protect the endogenous production of factor VIII. In the meanwhile, we are also providing factor VIII. So the level of factor VIII that can be achieved can be extremely high. That can be of help, but as I said, can be also, can cause some risk of thrombosis. The current treatment here, and it is a very simple slide, because as you can see, for the current treatment of choice, desmopressin is often helpful in type 1. Otherwise, of course, we can use concentrates, von Willebrand factor, factor VIII concentrates, when particularly in the severe cases of type 1. Otherwise, the treatment of choice for all the other types are von Willebrand factor concentrates, and the desmopressin can represent an alternative option in some cases, particularly 2A, 2M, 2N, but no more than this. For the type 3, as an alternative choice or as an additive treatment, platelet concentrates can be used. We have to consider that we have, it's difficult to see, but we have a number of products. Some of them have a published activity of efficacy in von Willebrand disease subjects. Some other have a limited or no published studies in these subjects. So many of them are products containing factor VIII and von Willebrand factor, but in a variable amount. So I would perhaps concentrate on the products that are the most commonly used, and the first one is Humate-P, because it was the very first that was used in von Willebrand patients. It's still used extensively in these patients. It is produced by CSL Behring. The initial approval date is 1986, but it was already used much earlier. It's a plasma-derived, it is pasteurized, and there is a high level of aristocytic cofactor activity, 2.4 in the relationship with factor VIII. Then it is alphanate and Fandi. They have different names in different countries, but more or less is the same product. The source of plasma is different. But anyhow, I mean, the initial approval date is even earlier, but the use in patients with von Willebrand factor is later. It's a plasma-derived. There is a double inactivation method, and the ratio is unspecified and variable. Anyhow, it's a ratio, shall we say, 1 to 1. So for 1% of 1 unit activity of factor VIII, there is 1 unit activity of ristocytic cofactor. And VIL8 is a more recent product produced by Octa Pharma. It's a plasma-derived, as well as a solvent detergent and dry teeth treatment, so a double inactivation method. And the relationship between RICOF and factor VIII is 1-to-1. And then the last one is BAX 111, is the recombinant factor A, von Willebrand factor. And it has been approved by FDA last year. And there is no factor VIII at all. So no ratio can be calculated. The dosing recommendation, these are taken from the National Heart, Lung and Blood Institute, so you can access it by yourself. It is very well done. I would say that it is a pretty, it is not recent because it has been published some years ago, but still very valid. You can see here the loading dose for major surgery or bleeding, severe bleeding, is 40-60 units per kilogram, and then the maintaining dose is 20-40 units. The monitoring is of ristocytic cofactor and factor VIII, and the best is to measure the trough and the peak, so before and after infusion, in order to have a precise situation of the situation. And the goal is to maintain both factor VIII and von Willebrand factor above 50 international units per deciliter, so 50% for 7-14 days. This is major surgery or very severe bleeding. For minor surgery or bleeding, of course, you can use lower dose, and also the monitoring can be less intensive. I put here some suggestion that anyhow belongs to the same recommendations. And for major surgery, it is considered cardiothoracic cesarean section 2, craniotomy, hysterectomy, open cholecystectomy, and prostatectomy. For minor surgery, you can see listed here. And for some other minor procedure, probably 1 single injection can be sufficient. So it is easily accessible if you wanted to access it. So, but this is the problem that we have to keep in mind. The problem is that with the red line, you can see the ristocytic cofactor, and these are days after surgery. And with the blue line is the level of factor VIII, and the arrows are the infusion. So the, shall we say, daily infusion or even more frequent infusion at the very beginning. So what is happening? That of course you provide immediately the right dose of von Willebrand factor and factor VIII. But then to this dose of factor VIII that you are providing to the patients with the concentrates, will add the factor VIII that is endogenously produced by the patient and protected by the Willebrand factor that you have given. So for this reason, you have very high levels. So you can see that can go up to 400 units per kilogram, and cases of thrombosis have been described with these levels. And why? Because there are constant level of, constant, sustained, high level of factor VIII, plus risk factor like surgery. So that is per se, as you know, a risk factor of thrombosis, and then perhaps even immobilization. So this is something to keep in mind, and this is something why it has been thought to have a pure recombinant von Willebrand factor. I will jump this for the sake of time, and it's a pity, but and I will just tell you about ultra-large multimers that in effect this is how von Willebrand factor is produced, but then as soon as it enters in the bloodstream, it is then cut it in pieces by Adam's 13. So you can see here what the example with and without multimers. And you can see that in the blood, the percentage of ultra-large multimers is 100%, but all the other concentrates have a very limited amount of them. And this is the production process of von Willebrand factor, and as you can see, this factor is produced starting from the same production method of add weight, and but then where factor VIII and von Willebrand factor are produced together, then they are split in two. And I mean, I know that at the time, but the mistake was not mine, and I'm trying to be fast, but because I understand that there is already the next meeting. And this is what is happening to ultra-large multimers. They last for some hours, but then they are cut by Adam's 13. So you don't have the same situation that has been described before by the colleague that was speaking before, that where you have a sustained high level of ultra-large multimers circulating in the blood of the patients. So I will cut this because I don't have time. I will just speak about the differences between plasma-derived and recombinant factors, and particularly the presence of ultra-large multimers, the intact subunits of von Willebrand factors, and the other things is that with plasma-derived von Willebrand factors, of course, there are other proteins, including Adam's 13 itself. So this is the clinical program that has been completed, and some others are planned or ongoing. And I would conclude that probably recombinant von Willebrand factors and that are and many will be available in the future, will be another piece in the puzzle of the treatment of patients with von Willebrand disease.